Welcome to Stallside Podcast.
Bart, how goes it today?
It's great, Peter. How about you?
Good, thanks. Pretty excited today. We've got my friend and colleague, Dr. Bill Gilsenan, on the show to talk about Rhodococcus Equi.
Friend, colleague, and roommate, right?
Yeah, that's right. We share an office, and, well, everybody's entitled to one mistake. It's probably his mistake.
Bill's a fabulous guy, and I'm excited to have him on the show. And this is an unfortunate disease that we deal with every day, and we don't always win.
Yeah, Rhodococcus equi is serious. It's got big teeth, and it likes to eat foals. And so I'm really looking forward to Bill's insights with the cases he's dealt with and what the latest information is.
Yep, it's getting tougher and tougher to treat, so...
Yeah,
let's talk about it. So, would like you to remind you to like the show if you do, and share it with all your friends. Subscribe if you feel so inclined, and help us get the word out.
Yeah, welcome to Stallside today. Up after the break, Dr. Bill Gilsenan. Bill, welcome to Stallside.
Thanks. Thanks for having me.
Thanks for joining us today. Appreciate it.
My pleasure to be here.
Yeah, so Bill, tell us a bit about yourself.
Well, I grew up in New Jersey, and I knew I wanted to be a vet from probably when I was like 7 or 8 years old. That was always the plan, but I'd only really been exposed to small animals and spent summers in college and high school working at a vet's office, and was pretty dead set that was what I wanted to do. And the vets that I worked for told me that I really needed to get some large animal experience if I wanted to get into vet school. And from there, things took off. When I started vet school, I kind of had an idea that I might be interested in mixed practice, but the more and more I got exposed to large animals, the more I was interested in pursuing that route. So ended up going to vet school at the University of Pennsylvania. I graduated in 2008, and then went on to an internship at Colorado State, and then back to University of Pennsylvania for my residency. And at that point, I thought I wanted to be at a university setting, and was lucky enough to get a job at Virginia Tech, and had been there for a couple of years. And while I was there, I guess I was looking for something different. The more time I spent there, what I really missed was being in a busy hospital. And I talked to Dr. Schnobrick, who we were actually vet school classmates, and we were also residents together. And so I think we were friends, but we also had a working relationship. I think she thought this was somewhere I might fit in. And when she told me they were looking for somebody, I got in touch with you guys, and I came here in 2015 and have been here since, and love it here. It works.
Yeah, no, you were highly recommended by Dr. Schnobrick and lived up to the expectations. We're glad to have you here.
That's good.
Yeah, you got one cross to bear while you're here, though. Your office mate.
Well, my office mate is across the table looking at me, so I can only answer pointed questions. What would you like to know about him?
Yeah, he doesn't sound like he's a very good person to share a room with.
He makes for good conversation.
Yeah, well, at least he has his uses.
When you can understand him, right?
Just not many of them. Well, yeah, I mean, it's taken a few years. It's finally, I had to give him a little instruction book for a start.
Yeah.
The masks posed an unanticipated difficulty, but we've persevered.
Oh, my word,
Yeah.
I can imagine.
You couldn't see the mouth moving, but the noise kept coming. So, Bill, we got you here today to talk about Rhodococcus equi.
Okay.
So, away you go.
All right. Well, to start off, I guess explain what it is, or what would you?
Yeah,
Okay.
absolutely.
So Rhodococcus equi is a bacterium that causes a granulomatous pneumonia in foals. What we'll typically see it in foals are, we say 1 to 6 months is the period at which they're susceptible. I would say in central Kentucky, we see it in foals mostly between 30 and 90 days as far as those presenting with pneumonia. There's probably so much we could talk about Rhodococcus, but probably some of the highlights I would say is that it's an extremely challenging disease to treat for a number of reasons, and two, we'll sometimes see Rhodococcus extend to other parts of the body, and those foals tend to be a little bit older, I guess is what I've perceived, maybe more like 3 or 4 months, where they can get huge abdominal abscesses, they can get joint infections, bone infections. They can even get meningitis or heart disease from it. It kind of comes down to wherever that bacteria is going to set up and cause a severe infection.
Yeah, it's a sobering disease, I've found. I mean, Rhodococcus, we felt like we had a bit of a handle on it for a while, and it's actually proven to be a bit challenging in some situations. So I'm a client I have a foal. I bring this foal into you. You diagnose Rhodococcus. How do you go about diagnosing Rhodococcus? And what are the things you're looking for just from your clinical exam that give you an idea that this may be a factor?
Yeah, absolutely. So we'll see Rhodococcus quite a bit this time of year and then earlier in the spring when foals are at that susceptible age. And sometimes you just go by signalment, being the age of the horse, and also what we see on ultrasound. There are a number of bacteria that can cause pneumonia in foals that age, strep being the other major one. So it's important for us to distinguish between the two of those because the treatment might be different. On ultrasound, what you'll see is probably one of the most helpful ways of diagnosing Rhodococcus is you'll see these really well circumscribed abscesses that if you've seen them, you'd recognize them in a second. But the best way of definitively diagnosing the infection is to do a tracheal wash. And try to culture Rhodococcus, but there's only certain strains of Rhodococcus that are capable of causing disease. So what we'll recommend doing is a PCR for a plasmid called VAP-A, that the Rhodococcus strains that can cause pneumonia in foals will come back as positive, and that helps us to confirm the diagnosis.
That's the thing that really surprised me about Rhodococcus is just how widespread it was. And now how not every foal that gets exposed gets the disease. What's your understanding why that is?
I think there's a number of reasons why. One of those probably has to come down to how much Rhodococcus the foal gets exposed to when it gets infected. What we do know is that foals get infected fairly early in life, probably in the first few days or weeks of life. So the infective dose is probably going to have a big bearing on how early they develop signs, how severe the signs, and how severe the signs are as well. Other factors have to do with the foal's immunity. You know, how well overall is it equipped to deal with infection and to fight infection off?
You mentioned about Rhodococcus ultrasound and finding it in the lungs. You also mentioned about abdominal abscesses. As an owner, would there be any other places where I'd have to be concerned that Rhodococcus may cause an infection in my foal?
Absolutely. So as I mentioned earlier, is that Rhodococcus can infect a lot of parts of the body, almost any part of the body conceivably, even though it typically starts in the lungs. If I diagnose a foal with Rhodococcus pneumonia, I'll always recommend an abdominal ultrasound to make sure that there's no evidence of an abdominal abscess, because that would change probably the foal's prognosis to some degree. There was a study out in 2009 in the Journal of American Veterinary Medical Association that indicated that upwards of about 75% of foals will have extrapulmonary disorders. And those, again, can occur throughout the body. And generally, I think of them as kind of an indicator of the severity of infection. So it is important to check the foal for evidence of osteomyelitis, which would be infection of the bone, or arthritis, which would be infection of the joints.
So that changes your prognosis, but does it change your treatment plan?
It typically doesn't. So when we were talking about the challenges associated with treating Rhodococcus, one of the biggest is that there's a limited number of antimicrobials that we can use safely in foals that will treat Rhodococcus. And typically what I recommend starting is either doxycycline with rifampin or clarithromycin with rifampin. So no matter whether you see simply pneumonia or you see an infection elsewhere, you're going to start with the same antimicrobials empirically. And the best reason for trying to figure out the extent of infection to start off with is one, prognosis, but also to know what to expect after you've established a baseline from the first treatment, the first evaluation.
So you mentioned that it's a hard disease to treat. Can you touch on why that is? Why it's different than say a strep pneumonia?
Absolutely. There's a couple reasons. One would be the limited number of antimicrobials. So there is recent research that points to the fact that resistance to these antimicrobials that we use commonly is increasing. So that poses as a challenge. The second aspect of the disease that makes it difficult to challenge or difficult to treat is that typically once we start seeing clinical signs of pneumonia or other disease, the foal has a pretty established infection. Like I said, infection usually occurs in the first few days or weeks of life, but we don't see signs earlier than 30 days, more like 60 to 90. So what we're seeing is this foal has been sick for a while, and it's only now starting to show signs of disease.
That's really sobering what you said about 3/4 of foals that have lung disease are actually going to have disease in other places. And I think that's something that a lot of people have trouble getting their mind around, and they focus on the lungs and they don't look at the rest of the foal, and maybe the disease clears up there, but there's mortal disease somewhere else. So what can be the outcome of these foals? I mean, if this disease progresses unchecked, you've talked about how difficult it can be to treat and how resistance to drugs is actually forming. Mm-hmm. If we can't get this infection under control, what happens?
Well, ultimately, I think that unfortunately, this is a disease that results in mortality for a lot of foals, and we'd hate that to be the case. But it's a tough disease to treat. Foals have abscesses in their abdomen. They start to lose weight. Their hair coat will get dull, and they're just not getting enough nutrients because they're putting so much of their energy into fighting off this infection. Foals with pneumonia can get to the point where they have trouble breathing and need to be put down because they can't simply exchange enough gas to do what they need to do. So it depends on where the disease is most severe, but certainly this infection can be severe enough that ultimately euthanasia is the only kind thing to do to that animal.
Well, one of the side effects to all this too, especially when you get these abdominal abscesses, you treat them for weeks and weeks and months, and you're on macrolides, so they're not going out in the sun. And so you've got a mare and a foal that are locked up in the stall for so long, and I can't tell you how many times we've seen where we get them through what we think we've got them through the Rhodococcus, and then they're OCD factories after that, and just because the animal has fallen apart on us. So that's one of the side effects I think that people don't think about.
Yeah, and it's such a profound inflammatory reaction that these foals have. And you will have seen this too, and you too, Bart. I mean, sometimes their eyes cloud over, and clients get really concerned. Oh, my foal's blind. We need to stop. Well, that's just a function of the severity of the inflammatory reaction. So, is this a disease in your experience that you've just sort of seen sporadically, occasional cases on a farm, or do you sometimes see it in outbreaks? And what about that herd? Is it like small groups of foals, big groups of foals, or can it occur in any situation?
Yeah, it can occur in any situation because we know that Rhodococcus is a bacteria that's ubiquitous in the environment. But we'll tend to see that certain farms or certain places have more severe infections than others. And a lot of that probably comes down to stocking density of the foals. I think if you are worried that your farm has a problem, if you can decrease the density of foals, that's going to make a big difference. The other thing that's really important is ventilation. Again, foals get infected by inhaling the bacteria. So if they're in a very well-ventilated area where there's an area where dust is minimized, that's going to decrease that period of time in the first few weeks of life that they're most susceptible to getting infected from it.
So if I have a herd of foals and I'm looking to check them out, what sort of protocols can I follow to actually see if this is a problem on my farm, how many cases I have, and what would be the parameters that I'd need to treat those foals with? How would I assess whether I needed to treat the individual foal in that situation?
Absolutely. That's a great question, and unfortunately, the answer is not crystal clear. What we'll recommend to a lot of farms is to go about with Rhodococcus screening, which means doing ultrasounds on the chest of all foals. Every farm is different. Every vet is different in what they're going to recommend. But generally, it's starting to ultrasound them as early as 30 days and at either 15 or 30-day intervals after that. And what you can use is look and see if there are Rhodococcus abscesses on your ultrasound that might give you an indication that this foal has what we call subclinical disease. And that means that they're sick, but they're not showing clinical signs yet. Based on the number and the size of the abscesses, it might be indicated to start treating those foals.
What about blood work? Like, blood work's pretty routine in a lot of situations to monitor how things are going. Have you found blood work to be useful or not so useful?
Yeah.
Well, specifically, I think, we had some hopes for SAA when it first came out.
Yeah.
Yeah, and that's, I think blood work is helpful. One of the most reliable blood work abnormalities I'll see on a foal with a bad Rhodococcus infection is a really high white count. So a normal white blood cell count would be between 6,000 and 12,000, and a lot of these foals will have white blood cell counts of over 18,000. That doesn't mean that a foal with a normal white blood cell count doesn't have Rhodococcus, but if it's got a high white blood cell count, that's going to increase my index of suspicion quite a bit. Fibrinogen is another indicator that we'll see in our blood work that often goes up with Rhodococcus infection. But like Dr. Barber said, serum amyloid A is a diagnostic tool we've been using for probably the last 5 or 10 years, and there are some instances in which I think it's helpful, but with Rhodococcus infection, it seems like it isn't. The research has shown that for whatever reason, serum amyloid A does not go up very much in cases of Rhodococcus equi. So you can get it higher if you have a co-infection with a different bacteria, but if you have a low number, that does not rule out Rhodococcus equi by any means.
Because this disease is so sneaky and it is actually well established before we actually have signs that it's going on, do you think that plays into SAA's difficulty in helping us diagnose?
I suppose that it could. I don't know that I've completely come to a conclusion about how I use SAA in management of anything. I mean, there are some disease processes that will cause serum amyloid A to go quite high, like, say, enteritis or diarrhea, that don't necessarily require specific treatment. Even horses with any sort of GI inflammation might get a high SAA, but I don't know if it's going to tell me exactly how to treat them. So likewise, I think it's almost equally confusing how Rhodococcus equi doesn't, but I think that your idea is that when it infects the foal, it lives inside the cell and it kind of brews there for a few weeks until it spreads to the lymph nodes, and then it causes an infection there, and at that point it becomes more disseminated. But even these foals that have raging infections and really high white blood cell counts and are clearly sick and have high fevers won't have high SAAs. So I think that might be part of it, but I don't know that that's all of it, and that might have to do with our understanding of how that inflammatory mediator works with respect to the infection itself.
So the bottom line is, though, for screening, ultrasound, if you want to do a screening program, ultrasound's our best bet.
Absolutely, yes. Screening is best accomplished by ultrasound, and to add another element to the challenge is that there's plenty of research from the last 10 or 15 years that shows a lot of foals with mild pneumonia and small abscesses will resolve on their own, and that's when it becomes a real challenge to figure out which one of these foals do you treat, because the more we treat, the more we're exposing the foals to antibiotics, and the more we're exposing to antibiotics, the more we run the chance of resistance. So you don't want to over-treat, but at the same time, you don't want to under-treat, and it becomes a really challenging, I think, line to walk.
Yeah, I find that a really difficult conversation with clients. Sometimes it's really difficult to get across that this is a situation, even though disease is present, we're not going to treat, because best to monitor and see if we develop sufficient disease. Because as you say, some of these foals will mount a successful response and get over this, because it seems to be a bacteria, and I mean it infects people as well, where there's just some immune deficiency, and as the foal develops a more normal immune response, it has a better ability to fight it off. So how do you have that conversation with a client when you are in a screening situation, you find disease, you think it's Rhodococcus equi? How do you tell them that maybe this is not one that we want to treat? And what's the rationale besides the resistance?
Yeah, absolutely. I think it comes down to, I think, the rapport that a veterinarian has with the farm and the background that they have with the farm. I think if there's a specific foal that you're worried about, depending on the ultrasound findings, I'd recommend pursuing some lab work and trying to get an idea, how severe is this infection? If the blood work is normal, I think you probably got more to gain for the foal to recheck the foal in a week or 2 weeks and making sure that disease isn't getting worse. But it comes down to a judgment call. You know, I think if you go back 10 or 15 years, I think for a period of time, some people thought it was maybe best to just blanket treatment all the foals with azithromycin or clorithromycin. And what we found was, while that helped in some respects, it kind of made it a little bit more difficult for us these days, because clorithromycin and rifampin resistance is an emerging problem.
Yeah, there was a very sobering study done in this town where, when screening started, things got treated, and then at about the 8th, 9th year, resistance just went through the roof. Yep. And it took a long time to build up, but once it happened, it took off. And so, yeah, we've learned a lot, right? I mean, ultrasound's a great tool, but we've learned a lot about how to use it more effectively. So this sounds pretty severe. Besides the things you've talked about as far as management goes with stocking density and dust, anything else preventative that you can think of that we can do now, or anything that's coming down the pipeline that might help us?
Yeah, obviously. Well, I think as far as prevention goes, and in light of recent events in all of our lives, I think we know that vaccines may be one thing that would help with prevention of disease. And Rhodococcus, a vaccine for that disease has been really difficult to develop. And there's a couple of reasons why. One of those has to do with the fact that this bacteria is going to go in the cell. So it infects a foal really early, and it's almost virtually undetectable until it starts showing some severe, at least disease, whether clinical or whether you look and try to find subclinical disease. The other thing that's really interesting is that for the most part, foals are really the only horses that are going to be susceptible to getting a Rhodococcus infection. So there's something that happens early in life that makes a foal or a horse resistant to getting sick with this problem. So there's probably a complex interaction of how the immune system works, and cell-mediated immunity is one part of the immune system that has probably a really important role in instilling this basically innate resistance to Rhodococcus when foals reach a certain age. That being said, vaccines usually work on a different part of the immune system, which is called the humoral immune system, and that's the part of your immune system that generates antibodies, and that's how a lot of vaccines work. So in the last few years, there's some research that's come out of Texas A&M and in conjunction with Harvard that has looked at developing a vaccine that's kind of the same mechanism how people with tuberculosis would get vaccinated. And that showed some promising results. It seems like these mares that get vaccinated before delivering their foals don't seem to get pneumonia. But that being said, those are small numbers right now. The data is probably the most promising that it's been. But that being said, it's probably years until that's going to be something that's mainstream. Along those lines, I discussed antibodies, and we're probably all familiar with how foals will get plasma when they're within the first few days of life. And like I said, cell-mediated immunity is what's of primary importance in preventing Rhodococcus. But if we give them antibodies, there's some evidence that may mute the infection or make it less severe, but it certainly does not prevent disease and is not a substitute for proper management.
You talked about plasma. There's been some recent information about the amount of plasma that's given. Would you like to talk about that?
Absolutely, yeah. So the initial research that was done is talking about giving plasma and making sure that foals get enough antibodies so they have adequate passive transfer, was done on smaller foals, and that was 1 liter of plasma. And what it looks like is that 2 liters of plasma might actually be better. And some of the research that been done for Rhodococcus equi showed that 2 liters of plasma may be more effective than 1 liter of plasma.
So I've got a farm and I had a foal with Rhodococcus a few years ago, and now I have another foal with pneumonia. Does Rhodococcus ever go away?
That's a great question. And unfortunately, it doesn't seem like it does. As I've already mentioned, Rhodococcus is ubiquitous in the environment, and it's in the dirt. And once it's there, it's not going to go away. So whenever a farm has a problem with Rhodococcus, I always advise, even years down the road, they're going to be at risk of having foals that can get sick from pneumonia.
What's the most challenging case of Rhodococcus equi you've had in a foal?
Probably the worst ones that I've dealt with are the foals that have abdominal abscesses, I'd say by and large, because we can find them by ultrasound, and I think by the time you see them, they're likely a lot bigger than you can even imagine on ultrasound, because ultrasound's only going to allow you to see several centimeters deep, and I find that for the foals that we don't save, those abscesses are always so much bigger than we estimate that there are. And that's not to say that I haven't had foals with abdominal abscesses that we've been able to treat. But I guess my general sense is once they're over 6 or 7 centimeters in diameter, you don't have a lot of success with treating them. So those have been tough ones. I mean, I've had foals that have been on antimicrobials for 30 to 60 days trying to get these infections under control. And sometimes you get lucky and they do. I think if you see the abscesses start to get bigger, that's a bad sign. And sometimes you can switch antibiotics, but I think there's probably just too much infection to clear for that foal. And like Dr. Barber said, it's a huge toll for them to go on because they're not doing all the things that they normally do because they're sick. I've seen bad cases of uveitis. The uveitis, when we talk about extrapulmonary disorders, that's one of the ones that we know is associated with a poorer prognosis than foals that simply have pneumonia. And that seems to be also an indicator of the severity of infection, but we've been able to bring foals from that too. So starting at square one, if I see a foal, even though no matter how bad it looks, if the client wants to try and treat it, I think there's always reason to treat as long as you don't think the foal is suffering. And it started at baseline, but sometimes it's important to temper expectations.
How about those cases that get in the bone? You know, the vertebral abscesses or, osteomyelitis elsewhere. Those are the ones I found just can't be treated. Do you have any luck with those?
Yeah, I think once you start seeing clinical signs, whether it be that they're lame or that they're neurologic, I think you rarely do. Have we saved them? Yeah, I think of a couple that we have, but it's a huge challenge, and I think that it's easier to have that conversation on day one that this is going to be really difficult to deal with. And so we don't get 7 or 14 days in and say this is not getting better.
That's the unfortunate thing is as you think about rhodococcus, you think about pneumonia, coughing, hacking, but that's not always how it shows up, right? It might be the neck pain, the lameness, or a lot of them present with diarrhea.
Yeah.
And so how does the diarrhea, I surprise people sometimes. They'll call you with a 120-day-old foal and it's got raging diarrhea and a fever, and you start looking at their lungs. How does the rhodococcus relate to diarrhea?
Again, I think it just depends on where it's causing disease. And, the GI tract is important for absorbing and secreting water. And if there's infiltration of that infection into the GI tract itself, it may get to the point where it's not going to absorb water appropriately, and that's going to potentiate the diarrhea. So that, along with the fact that the bacteria can upset the balance of flora in the GI tract. So when they develop rhodococcus diarrhea, it can be really difficult to get under control because one of the things that we treat them with is oral antibiotics, and what causes diarrhea in a lot of horses, oral antibiotics. So that would be one of kind of the many lists of body systems that can get affected, that can be really difficult to clear infection.
We talk about it forming abscesses, but it can actually cause an ulcerative colitis. So anybody that's listening that knows about that condition knows how severe it can be. And so, the gut can just get really, really scraped up by this.
So where do you think the hope is? Is our best hope to try and prevent infection, or we need to look for better treatments? Because, as Peter said, it's getting tougher and tougher to treat. And you mentioned A&M. Texas A&M has done a ton of work on this, and they've been at the forefront of it.
I think that's probably the most promising right now. I mean, I guess I've been a vet for 13 years, and since I've been a vet, I know that everyone's always been looking for a vaccine, and this seems to be the most promising information. That doesn't mean that it's necessarily going to work, but as far as we've gotten, I think they've come out with a really clever way of trying to come up with a vaccine for this disease. But I wouldn't expect that for at least 5 years. Ultimately, I think it comes down to prevention. And while there are other antimicrobials that can treat or might be able to treat, the ones that we go through, they're going to get more expensive. They might have other side effects. And ultimately, if we keep on treating more than we need to, which when you're looking at the individual animal, it can be really difficult to make that decision to not treat that animal that's sick when you have an owner that wants to save the foal, is that inevitably you're going to get resistant. So, if new antimicrobials come onto the scene, great, but that's only going to be, it's only going to fix things for a period of time. So I think ultimately it's going to come down to a vaccine. And in the meantime, I think management of the environment is the best way. So again, I think if people know that the earlier the foal is, the younger the foal is, that's when it's most susceptible to infection, is really think about husbandry practices that are going to minimize those foals getting infected.
Yeah, and to Bill's point about the vaccine being really difficult to create, like if you're a mouse, you're an excellent lab animal. And mice are really good models for people because people get rhodococcus, right? If you're immune suppressed for any reason. And so mice are a great model for people. They're a poor model for horses. And so the only way to really research on a horse is to use a horse. And that's really difficult to do.
Takes a whole season.
It takes a whole season. I mean, you can't order up a box of foals off Amazon. Yeah. They only come a certain time of year. And so it makes it really difficult to actually do that.
And it's hard, too, because you also need to experimentally infect them. So you need to, these foals will get large amounts of rhodococcus that, they put into the trachea to challenge them. And that's, it requires a lot of resources.
Yeah, no, I've helped with some of those studies before, and that was the difficulty, was you'd be doing the experiment, but then we had a good year, and nothing got rhodococcus, because they're naturally occurring infections, so it's tough.
It does wax and wane a little bit.
Yeah, and I think we've probably all worked in different places. I think for me, Rhodococcus is most severe in central Kentucky, and I think that's just because of the density of the foals that we see here. And I think if you go to other densely populated areas for foals, you're going to see the same problem. And that really picks up, I think, with the underlying theme is that's what's going to make it worse for some farms than others.
You make a really good point, Bill, because I was here when the global financial crash, like 2009-10. Rhodococcus just didn't come through the clinic.
Yeah.
When people depopulate, you're talking about stocking density, and I think you brought up a really important point there. There were less foals, there was less density, there was way less Rhodococcus. We just did not see the cases in the hospital because the disease just didn't happen.
You know, what's interesting, though, is we have this, there's been lots of theories about how it's transmitted, and I think we have a pretty good handle on it. But at the same time, this has been a really wet summer. You'd think dust low, be less likely to infect horses. And we've had foals who were stuck in stalls, right? So they weren't out on the ground eating the grass, inhaling the dust. They still get Rhodococcus. It seems at the same rate that foals who are outside. So I still think we have some things to learn about the transmission of the disease.
Yeah, you're right. I think that Texas study Bill talked about, I think concrete floors was a risk factor. And you think concrete floors would be less dust, but, you know, we just don't fully understand this disease. I mean, we've struggled with it for a long time because it's really difficult disease.
Yeah, and I think one of the things that's really hard to even put a number or to quantify is, you know, is it becoming more pathogenic? And I think that's difficult to say if it is or it isn't, or whether, you know, our means of treating it just simply get limited with time.
And certainly our means of diagnosing it have improved, like you talked about earlier. So, okay, that's a good conversation.
Yeah, it's great. Well, Bill, I can't thank you enough for coming in here and talking to us about Rhodococcus. It's a very important disease.
Yeah, absolutely. Happy to be here. Thanks for having me.
Thank you.
That was Stallside with Dr. Bill Gilsenan talking about Rhodococcus Equi. See you next time.
Why the podcast? Rood and Riddle Veterinary Pharmacy has a relatively small marketing budget, especially when you compare us with our competitors. I understand that marketing is important, but telling people that you exist and what you do and why your products or services are different is a must. I thought about what makes us unique, and I realized I wanted to give people something of real value. That's how the podcast idea evolved. I wanted to use the money we had set aside for marketing, not to tell people who we are, but rather to show them, to open up how we do things and give something of value at the same time. The content of this podcast is designed to do exactly that. It's not going to serve as a shameless plug for pharmacy products or services. We want you to know who we are, that quality is uncompromised, that we care about people and their animals. If there are specific topics that you would like us to cover or guests that you would like to hear from, please email us at stallside@rrvp.com. Hope you enjoy the show. Just one more note. Nothing that we talk about here today should be construed as veterinary advice. That's why you have a relationship with your own veterinarian. Thank you for listening.